Hello guys, welcome back to Easy Medicine. I didn't want to clutter the entire coronary artery disease into one or two sections. That is why I extended this into the third section. In this section, we are going to discuss about the management of NSTE acute coronary syndrome. So we have the acute coronary syndrome, which is divided into NSTE or non-ST elevation acute coronary syndrome, which contains unstable angina and NSTEMI. On the other hand, we have ST elevation acute coronary syndrome, which is otherwise called as ST elevation myocardial infarction. So in this section, we are going to discuss about the management of NSTE ACS, management of STE ACS, and the complications of MI. That is our agenda in this section. Now let's start with the evaluation. We have already looked at the pathophysiology, clinical features, and etiology of the acute coronary syndrome in section 1. In section 2, we have looked at the management of stable angina, and this is section 3. We are going to look at the management of acute coronary syndrome. Let's start with this NSTE ACS. The evaluation starts with the basic investigation, which is an ECG. ECG shows ST depression or deep symmetric T wave inversion. And the cardiac troponins are going to differentiate between unstable angina and NSTEMI. So when you look at the cardiac troponin I or T, when it is more than 99th percentile at 0 or 1 hour, then it is diagnostic of NSTEMI. The troponins will be released only when the patient is having infarction inside the heart. So the infarction will release the troponins into the circulation, and presence of troponins in the circulation identifies infarction. The next step would be to assess the risk. So the risk stratification can be done to identify the risk of major cardiac events, or simply called as MACE. We can use any of these three scores. One is a hard score, which is the preferred one. H for history, E for ECG, A for age, R for risk factors, and T for troponin levels. These parameters are used for assessing the risk in these patients. And you can also use certain scores like GRACE or TIMI. TIMI stands for thrombolysis in MI. Even though we don't use thrombolysis in the management of NSTEMI, then TIMI is based on the study which is done in this group called as thrombolysis in MI study group. Okay, that is why the score is named TIMI. Let's look at the drugs that are commonly used here. The pharmacotherapy includes the anti-ischemic drugs and anti-thrombotic drugs. Anti-ischemic drugs include the nitrates, beta blockers, calcium channel blockers, morphine, ACE inhibitors or ARBs, and statins. These are all the drugs which are included under anti-ischemic group. Then we have anti-thrombotic drugs, which includes antiplatelet drugs and anticoagulants. What are the antiplatelets that we use here? We'll use aspirin and P2Y12 inhibitors like clopidogrel, ticagrelor, or prasugrel. We can also use glycoprotein 2B3A inhibitors, which are abciximab, tirofiban, epifebatide, all these drugs. And in the anticoagulants, we can use unfractionated heparin or enoxaparin or fondaparinux or bivalirudin. Okay, any of these drugs can be used under anticoagulants. So these are the drugs that are commonly used here in acute coronary syndrome. Now let's see stepwise. If there is any trouble remembering these drugs under these separate headings, you can simply remember this by using a mnemonic ABCDMNOPHS. A for AC inhibitors or ARBs, B for beta blockers, C for calcium channel blockers, D for dual antiplatelet therapy, M for morphine, N for nitrates, O for oxygen, P for prognostication, H for heparin, and S for statins. So ABCDMNOPHS can be used as a mnemonic for remembering all these drugs that we have discussed. Now let's delve deeper into these drugs. How are they useful? So nitrates, like we already discussed in stable angina, they are combined arterial venodilators. The systemic venodilation will reduce the venous return and thereby reducing the cardiac workload. And they will also do coronary vasodilatation, thereby increasing the supply. So demand is reduced, supply is increased. And for immediate relief, you will use sublingual or intranasal spray of nitroglycerin. This is usually used at a dose of 0.3 to 0.6 milligrams up to 3 doses 5 minutes apart, or you can also use intravenous infusion if the patient is not responding with this sublingual or intranasal spray. These nitrates are contraindicated when the patient is having right ventricular MI. When the patient has right ventricular MI, the patient will have hypotension and the patient will present to you with the features of right heart failure with elevated JVP. Okay, and the patient will also present with hypotension and shock. So when you reduce the preload, the right ventricular inflow of blood will be further reduced. This can precipitate shock. That is why in right ventricular MI, do not use or cautiously use nitrates and vasodilators. We need to give IV fluids in a case of right ventricular MI. And these are also further contraindicated in severe aortic stenosis. Phosphodiesterase 5 inhibitor usage like sildenafil, tadalafil, when you are using these drugs, they are already potential vasodilators. And when you give nitrates, this significant vasodilation can land the patient in hypotension and shock. And of course, hypotension is also a contraindication for the development of nitrates. The second one are the beta blockers. Beta blockers are negatively inotropic. They'll reduce the myocardial oxygen demand and they will further reduce the ischemia because the demand for the myocardium is reduced. They have shown to be having an effect on the infarct as well. The size of the infarct is reduced and there is decreased risk for ventricular tachyarrhythmias because it will also have the effect of AV nodal blockade and reduction in the heart rate. And the target heart rate with the usage of beta blockers is 60. And when should you not use beta blockers? The contraindications are acute decompensated heart failure. In a case of acute decompensated heart failure, stop using beta blockers. When the systolic blood pressure is less than 90 millimeters of mercury or the heart rate is less than 50 beats per minute. Or if the patient is already having some kind of heart blocks, the beta blocker is going to increase the heart blocks. And when the patient is having severe reactive airway disease, like we know in a case of chronic obstructive pulmonary disease or bronchial asthma, or even in a case of peripheral vascular disease, the beta blockers are contraindicated. The next group of drugs are calcium channel blockers. Non-dihydropyridine calcium channel blockers can be used as a third line if the patient does not have any relief of pain despite using the full dose of nitrates and beta blockers. Now let's look at the antiplatelet drugs. The antiplatelet drugs are aspirin and clopidogrel. So the aspirin should be given at a dose of 325 milligrams stat as a bolus dose followed by 75 milligrams orally per day. The dual antiplatelet therapy, that is a combination of aspirin along with the P2 Y12 inhibitor, that is a clopidogrel or ticagrelor, should be mandatorily used for 1 year, and after that you should continue aspirin for lifelong. Other drugs are the P2Y12 inhibitors. The drugs are clopidogrel, ticagrelor and prasugrel. The clopidogrel should be given bolus dose or a loading dose at a dose of 600 mg stat followed by 75 mg OD. The clopidogrel is metabolized by CYP2C19 enzyme and the polymorphisms of this enzyme can result in resistance. The next drug is ticagrelor. Ticagrelor, the loading dose is 180 mg stat followed by 90 mg twice daily. This is preferred and used when the patient is having clopidogrel resistance or if the patient develops myocardial infarction while the patient is already on clopidogrel. And third drug is prasugrel. The dose is a loading dose of 60 mg stat followed by 10 mg OD. This is approved in patients who are taken for percutaneous coronary intervention. There are certain contraindications for prasugrel. When the contraindications are the weight is less than 60 kgs and age is more than 75 and if there is any history of stroke or transient ischemic attack. There is something called as the triple antiplatelet therapy. It is nothing but a combination of dual antiplatelet therapy along with the glycoprotein 2B3A inhibitors. This is particularly reserved for unstable patients who have undergone PCI and for those who are still having ischemia despite the usage of dual antiplatelet drugs. The next group of drugs are statins. We use high intensity statins. The high intensity statin means an atorvastatin of 80 milligrams or rosuvastatin of 40 milligrams per day. And the statins will increase the stability of atherosclerotic plaque and they have shown to be reducing the peri-procedural myocardial infarction. That is, after you've done a PCI or CABG, if the patient is already on statins, after the procedure, the incidence of MI is significantly reduced with the usage of statins. And the recurrence of acute coronary syndrome has also been shown to be reduced with the usage of statins. That is why high intensity statins should be used along with dual antiplatelet therapy. Now let's look at the protocol. So these are all the treatment modalities that we have for the management of acute coronary syndrome. Now let's look at the protocol for the management of NSTE ACS. So we have already done the ECG and troponins. We have diagnosed that the patient is having NSTE acute coronary syndrome. The next step would be to do risk assessment by using the heart score. By using the heart score, we have differentiated into low risk or intermediate risk or high risk or very high risk. If the patient has low risk, you can go towards the conservative management. What constitutes the conservative management? Usage of all the three groups of drugs. That is usage of anti-ischemic therapy along with dual antiplatelet therapy and anticoagulants. All these three together constitutes the conservative management. And intermediate risk patient should be subjected to the invasive strategy where the invasive procedure like percutaneous coronary intervention or coronary artery bypass graft should be done within 72 hours. So this includes Usage of all these three modalities that we have already added, all the three groups of drugs, along with that we'll add percutaneous coronary intervention or CABG for reperfusion. That is what is the invasive modality here or invasive procedure here. According to hard score, if the patient's risk is high, then you should do the procedure within 24 hours. That is called as early invasive strategy. If the risk is very high, then you should do the procedure within 2 hours. That is immediately invasive strategy. Right? And there is no role for thrombolysis in the management of NST elevation or non-ST elevation, myocardial infarction or ACS. Now let's look at acute coronary syndrome management. Now you have identified the ST elevation ACS by looking at an ECG. Firstly, assess the duration of chest pain. Is it less than 12 hours or is it 12 to 24 hours or is it has it been more than 24 hours? If the duration of chest pain is less than 24 hours, then definitely do reperfusion. Reperfusion means either PCI or CABG. If it is between 12 to 24 hours, assess whether the patient is having persistent chest pain. Is there persistent ST elevation on an ECG or is the patient having heart failure? If any of them is present, then consider reperfusion even between 12 to 24 hours. If the patient's chest pain duration has been more than 24 hours, then there is no use for reperfusion. If you have decided that the patient should undergo reperfusion, the further management depends upon to which hospital that the patient has gone to, whether the patient has reached a PCI capable center or he has reached a center where the PCI is not possible. So if your hospital is a PCI capable center, then you should do primary PCI within 90 minutes. This 90 minutes is called as the first medical contact to device time. So the time interval between the patient coming to the casualty and the patient undergoing angioplasty should be less than 90 minutes. That is called as the first medical contact to device time. If the patient has reached a non-PCI capable center, then our goal should be to shift the patient to a PCI capable center within 30 minutes. That is door in, door out time. If your hospital is a non-PCI capable center, then as soon as the patient comes to the casualty, give the loading doses of aspirin, clopidogrel, atorvastatin, if at all required, relieve the chest pain with nitrates, and shift out the patient within 30 minutes. That is called as door in, door out time. And the first medical contact to device time should be maintained less than 120 minutes. That is, the first medical contact is at your hospital and the introduction of the device or angioplasty is some other hospital, but still the angioplasty at that hospital and the first medical contact in your hospital, the time interval between these two should be maintained less than 120 minutes. If it is possible, then shift the patient. If it is not possible, that is, there is no nearby hospital and it is not possible for you to maintain the first medical contact or device time to less than 120 minutes, then do fibrinolysis in that patient. Here as well, you should maintain the first medical contact to needle time, that is introduction of needle, should be less than 30 minutes. That is, the first medical contact to needle time should be less than 30 minutes. And after the fibrinolysis, shift the patient for angiography and revascularization after 3 hours but before 24 hours, between 3 hours and 24 hours. This is called as the pharmaco-invasive strategy. We have already given the pharmacological drugs, and you also want to send the patient to a bigger hospital where there is provision for PCI or CABG for reperfusion. So what drugs will we use for thrombolysis? The agents that commonly used are streptokinase. The dose is usually 1.5 million units in 100 ml NS over 1 hour. The other drugs that we can use are alteplase or a riteplase or a tenecteplase. The angiography and revascularization should not be done within the first 2 hours because as soon as you give thrombolysis, the thrombus is not completely lysed and it is very unstable. That can increase the risk of reocclusion. Now let's look at the contraindications for thrombolysis. There are some absolute contraindications and relative contraindications. What are the absolute contraindications? If the patient is having intracranial hemorrhage, obviously, right, it is life threatening. A cerebral vascular lesion or a neoplasm, again, that can bleed into the brain parenchyma. Ischemic stroke within 3 months, again, there can be a hemorrhagic transformation of the ischemia. Head trauma within 3 months. Intracranial or intraspinal surgery within the last 2 months. Severe uncontrolled hypertension. Suspected aortic dissection. Active bleeding but not menses. And usage of streptokinase in the last 6 months. So these are all the absolute contraindications for usage of streptokinase or thrombolysis. The relative contraindications are ischemic stroke more than 3 months ago. Dementia, systolic blood pressure more than 180 millimeters of mercury and diastolic more than 110 millimeters of mercury. Traumatic or prolonged cardiopulmonary resuscitation, that is approximately more than 10 minutes. If the patient is a pregnant, or if the patient has undergone major surgery within the last 3 weeks, if there is any history of internal bleeding within the last 2 to 4 weeks, or if there is an active peptic ulcer, and usage of oral anticoagulant therapy. So these are all the relative contraindications for the patient to undergo thrombolysis. So if the patient has reached a non-PCI capable center and it was not possible to shift the patient within 30 minutes, or if the first medical contact to device time cannot be maintained less than 120 minutes, then you should go for thrombolysis. So you have done the thrombolysis in your hospital. Then what? If the patient has become asymptomatic, then give him the routine care. But if there is any reappearance of chest pain or ST elevation, then immediately send the patient for coronary angiography and percutaneous coronary intervention. But if the patient is asymptomatic without any reappearance, then before discharge, do an exercise stress test in order to reassess the risk of coronary artery event. If there is any positivity in the exercise stress test, again send the patient for coronary angiography and percutaneous coronary intervention. On the other hand, if the patient is not asymptomatic, even if we do thrombolysis, if the patient is still having persistent chest pain, or if the patient is having persistent ST elevation for even 90 minutes after thrombolysis, or if the thrombolysis has failed to reperfuse the patient, then you should do rescue PCI. Rescue PCI means sending the patient for PCI within 24 hours. So we have two different kinds of strategies. One is the facilitated PCI and then pharmacoinvasive strategy. The facilitated PCI means firstly you'll give the patient thrombolysis and then glycoprotein 2b3 inhibitors like abciximab, and within 2 hours you will also do PCI. So you are subjecting the patient to both thrombolysis and PCI within the first 2 hours. This is not recommended because the thrombus is unstable and there is a high risk for reocclusion. This is not preferred. We also have another strategy which is called as the pharmacoinvasive strategy, where if you have done thrombolysis, you can shift the patient to a PCI capable center after 2 hours but within 12 hours, even in successful thrombolysis. This is actually recommended. After you thrombolyze, then you should do some post-infarction risk stratification because you don't want the patient to land up in reinfarction after you did thrombolysis. So do stress testing at discharge and 2 to 6 weeks in follow-up. If stress testing is shown to be positive, again do the coronary angiography and send the patient for reperfusion or the PCI or CABG depending upon the requirement. Now let's look at the complications of myocardial infarction. The first one is post-infarction ischemia. After an episode of myocardial infarction, despite giving the therapy, the patient may again develop infarction or ischemia. So when the patient develops this post-infarction ischemia, give vigorous medical therapy with or without PCI or CABG. The second one is AV blocks. The AV blocks are commonly seen with inferior wall myocardial infarction. Again, reperfuse the patient using PCI or CABG. The third one are the arrhythmias. There are different kinds of arrhythmias that can be seen in a patient of MI. The commonest ones are the ventricular ectopics. The ventricular ectopics are commonly seen in a case of post-MI. The intervention is not really required, they'll subside on their own. So the prophylactic antiarrhythmic is not actually recommended and beta blockers can usually abolish them. Then we have accelerated idioventricular rhythm, where the ventricular myocardial cell has taken over the entire heart. Now a ventricular myocardial cell is the pacemaker. The antiarrhythmic is not again recommended here. It will again resolve on its own. The next one is ventricular fibrillation or ventricular tachycardia. This arrhythmia is life-threatening. So you should intervene with usage of intravenous amiodarone or procainamide. If the patient is hemodynamically unstable or if the patient is in shock, then you can use unsynchronized DC cardioversion with 200 to 300 joules. If the patient develops this VT or VF within 48 hours, the patient will likely have a good prognosis. But if VT or VF develops in a patient after 48 hours, this is usually because of pump failure and it has poor prognosis. In such a patient, implantable cardioverter defibrillator should be placed. The next one is right ventricular infarction. This is little different. The right ventricular infarction presents with hypotension and the features of right heart failure like elevated JVP. When you look at the lungs are usually clear because the right ventricular MI means the right ventricular failure will not pump the blood out of right ventricle into the pulmonary artery, and blood will not be reaching the lungs. When you look at a chest X-ray as well, there is oligemia in the lungs. So the lungs are usually clear on examination. The treatment requires IV fluids rather than vasodilators and nitrates. So give 0.9% saline 500 ml over 2 hours. You can also use inotropics if required if the patient is having hypotension, and cautiously use nitrates and diuretics because both these drugs will reduce the preload, and if the patient is already having hypotension and shock, the reduced preload is going to deteriorate the patient. The next one is left ventricular free wall rupture. When the LV free wall ruptures, the blood will accumulate in the pericardium or in the thorax and the patient will immediately die. The next one is left ventricular aneurysm. This can be identified by looking at the persistent ST elevation beyond 4 to 8 weeks of myocardial infarction. Even after 4 to 8 weeks of myocardial infarction, if the ECG is still showing persistent ST elevation, then you should suspect left ventricular aneurysm. The next complication is pericarditis. There can be an immediate pericarditis or a late pericarditis. Immediate pericarditis means it should develop usually between 2 to 7 days, that is less than 1 week after a myocardial infarction. This can be treated like any other case of pericarditis, that is, we'll give aspirin at higher dose of 650 milligrams 4 to 6 hours, and that will relieve the pain. And anticoagulation should be used with caution because when the patient is having pericarditis, when you give anticoagulants, this may result in hemorrhagic pericarditis. So, cautiously use anticoagulation. The late pericarditis is Dressler syndrome. This Dressler syndrome develops after 1 week and within 12 weeks. So, in between 1 to 12 weeks after an MI, if the patient develops pericarditis, it is called as Dressler syndrome. This is an autoimmune phenomenon, and the patient can have fever, leukocytosis, and pericardial effusion. Again, we'll treat with a short course of NSAIDs or corticosteroids if required. This is all about the complications of myocardial infarction. Lastly put, this is a summary slide for the management of MI. So firstly, we have a conservative or ischemia guided therapy where we'll use aspirin, clopidogrel, and anticoagulant. The second one is an invasive strategy or a percutaneous coronary intervention. Here, again, you'll use all the three drugs that we have mentioned in the conservative strategy. Along with that, you are going to do PCI, and then in high risk patients, you are going to add glycoprotein 2B3A inhibitors. That is an invasive strategy with PCI. And then you can do CABG. But before CABG, what are the steps that you should take? You can give aspirin, but the aspirin can be continued, but stop clopidogrel 5 days before and stop prasugrel 7 days before. If you want to do CABG today, you should have stopped clopidogrel 5 days ago and you should have stopped prasugrel 7 days ago. And if you want to do an urgent CABG, there is no time for you to wait for another week. If you want to do urgent CABG, then stop clopidogrel at least 1 day before CABG. And you should stop glycoprotein 2B3A inhibitors 2 to 4 hours before surgery. After CABG or PCI, how long should you continue the drugs? Aspirin should be continued indefinitely, and the P2 white well inhibitors, that is, or the dual antiplatelet therapy, should be continued at least 12 months. The P2 white well inhibitors, that is clopidogrel or ticagrelor or prasugrel, along with aspirin, should be continued for at least 12 months. So the 12 months of dual antiplatelet therapy is mandatory, and after that you will indefinitely use aspirin. This is all about the acute coronary syndrome. If you like this video, please share and subscribe to this channel. Thank you.